Hello guys and welcome to my channel. Today we are going to have a discussion on the topic of drugs for asthma part 2. So we will be covering our topic under the following headings. So the first drug that we are going to cover is the corticosteroids. Now as we have discussed in the previous lecture that corticosteroids can be given in both the inhalational as well as the systemic forms. So if you have not checked out that lecture then please do check it out. The link will be given in the description box as well as in the I button above. So, what is the mechanism of action of corticosteroids? The corticosteroids they enter the target cells, and when they enter the target cells they bind to the glucocorticoid receptor. This steroid and the glucocorticoid receptor complex then moves into the nucleus. Once they move into the nucleus, this complex of steroid and glucocorticoid receptor, it binds to the coactivators and inhibit the activity of the histone acetyl transferase or HA2, and this inhibition occurs in two ways. The first way is that this complex directly inhibits the activity of HA2, and the second way is that it recruits the HDAC2. This HDAC2 it actually causes histone deacetylation, and once histone deacetylation occurs then suppression of the activated inflammatory gene takes place. So in a nutshell, corticosteroids actually suppress the inflammation that occurs during bronchial asthma. The one thing to note here is that the receptor for the glucocorticoid is located in the cytoplasm, but the activity it takes place in the nucleus. So let us now have a look at what are the anti-inflammatory effects of corticosteroids in asthma. So the inflammatory cells are the eosinophils, the T lymphocytes, the mast cells, macrophages and the dendritic cell. So a detailed discussion on the pathogenesis of asthma is also done earlier. So the link will be given in the description box as well as in the I button above. Please feel free to check it out. As we can see that in eosinophils there is decrease in the number of the eosinophils. Now how does this decrease occur? This decrease occurs because the corticosteroids they increase the apoptosis or the programmed cell death. So because of increase in the apoptosis, the number of eosinophils is actually decreased. In T lymphocytes, it causes a decrease in the release of the cytokines. In mast cells, it also decreases the number of the mast cells. In macrophages also, it decreases the release of the cytokines, and in dendritic cell it also decreases the number of the dendritic cell. So in case of T lymphocytes as well as in case of macrophages, the release of cytokines is inhibited, and as we all know that cytokine acts as an mediator of inflammation. So since the mediator of inflammation is reduced, hence naturally the process of inflammation gets suppressed. Let us now have a look at the effect of corticosteroids on the structural cells of the airway. So the structural cells are the epithelial cells, endothelial cells, the airway smooth muscles as well as the mucosal glands. So in the epithelial cells, it decreases the release of the cytokines from the epithelial cells and naturally decreases the release of the inflammatory mediators. So because of this decrease in the release of the inflammatory mediators in the endothelial cells, what occurs is because of this inflammation, we know that the permeability of the cells is actually increased. So since there is decrease in the release of the inflammatory mediators, hence there is reversal of the increased vascular permeability. And once this reversal of increased vascular permeability occurs, the resolution of airway edema takes place. In airway smooth muscles, there is increased number of the beta 2 receptors. And these beta 2 receptors, they actually act as the receptor on which the beta 2 agonists act, and they lead to bronchodilation. In mucus gland, there is decrease in the mucus secretion. So what is the effect of the beta 2 adrenergic responsiveness? Now as we have already seen that the corticosteroids they are increasing the number of the beta 2 receptors on the respiratory smooth muscles. So how does this increase in the beta 2 receptor takes place? The increase takes place because of the increased transcription of the beta 2 receptor gene, and also there is increased stability of the mRNA. So since corticosteroids increases the transcription of the beta 2 receptor gene in the respiratory mucosa as well as increases the stability of the mRNA, because of these two reasons there is increased number of the beta 2 receptors in the airway smooth muscle, and also it causes prevention or reversal of the uncoupling of the beta 2 receptors from the G protein coupled receptor, that is G stimulatory type of receptor. Since there is prevention or there is reversal of the uncoupling, so the action of beta 2 receptors is actually increased. Now what does beta 2 agonist do for the corticosteroids? The beta 2 agonists, they actually increase the nuclear translocation of the ligand bound glucocorticoid receptor. That is, what we have already seen is that the glucocorticoid receptor, it will bind to the ligand, that is the corticosteroid, and then this entire complex will be going into the nucleus for it to act. So this translocation from the cytoplasm to the nucleus, the translocation is actually increased by the beta 2 agonist, and also it enhances the binding of the glucocorticoid receptors to DNA. Thus we can say that corticosteroids and the beta 2 agonist, they actually enhance each other's beneficial effects. So what are the side effects of inhaled corticosteroids? Now the inhaled corticosteroids, it can cause both the local side effects as well as the systemic side effects. So the local side effects include dysphonia, oropharyngeal candidiasis and cough. The dysphonia and the oropharyngeal candidiasis, they can be decreased by using spacers along with the MDIs. The systemic adverse effects such as adrenal suppression and insufficiency, growth suppression, bruising, osteoporosis, cataract, glaucoma and psychiatric disturbances occur. This adrenal suppression and insufficiency, this actually occurs in high doses, and adverse effects such as osteoporosis, bruising, cataracts, glaucoma and psychiatric disturbances, they are also seen in case of systemic corticosteroids. The next group of drugs that we are going to see, they are the leukotriene antagonists, and the drugs that we have in this group, they are montelukast and zafirlukast. So what is the mechanism of action for leukotriene antagonist? The cysteine leukotrienes such as the leukotriene C4, D4 and E4, they are produced by the macrophages and the eosinophils, and they act by the cis-LT1 receptor, and once they act or they rather bind to the cis-LT1 receptor, what happens is that it leads to bronchoconstriction, airway hyperresponsiveness, exudation of plasma, increased mucus secretion and eosinophilic inflammation. Now drugs such as montelukast and zafirlukast, they act as competitive antagonists at the cis-LT1 receptor. So once they are competitively antagonized, hence the agonists, that is the LTC4, D4 or E4, they cannot bind to the cis-LT1 receptor, and thus the effects such as bronchoconstriction, airway hyperresponsiveness, plasma exudation, mucus secretion and eosinophilic inflammation will not be occurring. So normally these are very safe drugs, and some of the adverse effects that we have seen are, it can cause abdominal pain, headache, rashes and a few rare cases of Churg-Strauss syndrome. The next group of drug that we have is the anti-Ig receptor therapy. The drug that is given for this purpose is omalizumab. So what is the mechanism of action of omalizumab? Omalizumab is a humanized monoclonal antibody. This omalizumab, it blocks the binding of the immunoglobulin E to its high affinity receptors, that is the Fc epsilon R1 on the mast cells. So since the binding of the Ig does not occur to the mast cells, hence their activation by the allergens is prevented. Also, this omalizumab blocks the binding of the Ig to the low affinity receptors such as the Fc epsilon R2 and CD23 that is present on the T and the B lymphocytes, on the macrophages as well as on the eosinophils, and because of this the process of chronic inflammation is inhibited. This omalizumab also reduces the level of the circulating IgE. An uncommon adverse effect that is associated with the use of omalizumab is anaphylactic response. So let's wrap it up for today. The upcoming lecture will be on the GINA 2022 guidelines. So if you like this video, then give it a thumbs up, share it and comment down below to let us know what other topic we can discuss. And also subscribe to my channel and press the bell icon. Until next time.